screen. Share the screen. So today's today's topic is common pitfalls and mimics in shoulder imaging. So what I try to do is to divide my topic into modalities. So go through some plain film pitfalls, see if we can address them, CT, ultrasound, and MRI. So divided into four main sections. So directly going through some pictures. So this is not uncommonly seen, this appearance of humeral head, which gives like a cyst-like appearance within the humeral head. And this is another patient showing similar cyst-like appearance within the humeral head. This is a normal variant and should not be called as called as pathology and should not lead to further imaging. This is very common. Basically, it is a pseudocyst of humeral head. This is because of increased cancellous bone, especially in the region of the greater tuberosity, giving like a cyst-like appearance. All that you need to see is to look at the other projections and see if it is still shows a cystic appearance. And for example, this patient, there is no on the other view, there is no cystic appearance. So basically, this is a common pitfall where people tend to misinterpret. This is a pseudocyst of humeral head. The next one, sometimes on the X-ray, we see a indentation underneath the medial end of the clavicle, which is commonly seen. This is also it can sometimes mimic pathology. However, this is usually bilateral. It can have like a little bit of ragged appearance on the CT scan also. This is also not pathology. This is a normal variant. It's called rhomboid fossa of the clavicle due to close proximity to the first rib. It's just an indentation of bony indentation. It shouldn't be interpreted as pathology, especially for juniors. You need to remember the normal variations. This is a rhomboid fossa of the clavicle, the medial end. Again, sometimes we see this kind of a lucency or a raise in the cortex of the mid portion or at the junction of the mid and proximal third of the humerus. Basically, this also is not a pathology, or it can look like a lytic lesion or a destructive lesion, but it is not. Sometimes it has this kind of a flat appearance where there is when it is not acute or more chronic. You can see that the deltoid is attaching here. This is secondary to chronic avulsion from the deltoid. You can see that on the CT scan, just looks like a little bit of lucency within the cortex, and this is called as fancy. It's got a fancy name, pseudotumor deltoides. Basically, it is due to a recurrent chronic avulsion, and this is a do not touch lesion. So this does not need in that specific location. If you see this kind of appearance, this is specific for pseudotumor deltoides and does not need any further imaging. Okay, sometimes you may see a punched out lucency within the humeral head. It's not that commonly seen, and this is if you have an appropriate history, like previously it looked normal, this shoulder, and if there is a appropriate history, you can elicit from the patient that patient had some kind of surgery. Then this punched out lucency, which looks like a lytic lesion, can be secondary to a surgery for the long head of biceps, when there is chronic tendinopathy of the long head of biceps, the biceps, intra-articular portion of the biceps is excised, and the proximal biceps is anchored with the non-radiolucent anchors, which can't be seen on the X-ray. So this is a post-surgical appearance. Basically, we need to have a good history to say that this is not pathological. So this is a classical area where the lucency is found. So this is a post-surgical appearance, and you don't need to go in the route of lytic lesion if you know the history. This is a common pitfall, especially when you are a medical student or a junior resident, we tend to misinterpret the undulated appearance of the growth plate, epiphyseal plate as fracture. So this is a common pitfall among juniors when they don't see enough cases. So this shouldn't be interpreted as fracture. This is the epiphyseal plate which looks or can mimic a fracture. Sometimes you see radio density on the humerus, proximal humerus, and you can see this patient has a calcific tendinopathy as well. This patient, on the other views, it shows that it is actually not within the bone, or it's not a bone island. It's calcification outside, and it's is along the line of the long head of biceps. And this is a detached calcific tendinopathy, or sometimes there is a lot of degeneration, joint degeneration, could be loose body, which can drop into the long head of biceps tendon. It can be very symptomatic. It can cause problems, and this ultrasound of the same patient showing the loose body of the calcification, which has dropped into the long head of biceps tendon, and this can be symptomatic or can give clicking appearance or biceps pain along the biceps tendon. So we need to remember that this can happen. This is a possibility. You see such radiopacity. So these are some X-ray mimics or pitfalls. We'll go through some ultrasound pitfalls. As we know, sticking to the basics, anisotropy is one of the major pitfall in ultrasound. In inexperienced hand, anything you can show anything to look like either tendinopathy or tear by angling the probe or doing a wrong technique. So here you can see that this biceps tendon, which looks hypoechoic, but when probe is angled properly, it shows the normal fibrillar pattern in white echo texture, which is the normal how it should be. So in a experienced hands, it can be misinterpreted as tendinopathy or tear. I'll show you some examples. This is very common. A lot of people misinterpret this as a partial thickness tear if they're not used to doing a lot of scans. But when you angle the probe appropriately, then that low signal, low echogenicity disappears, and it looks. So you need to examine that area more closely when there is a doubt, and you shouldn't unnecessarily call it as a tear. So anisotropy sometimes can be used for your advantage. Sometimes when there is no biceps tendon and there is fluid or echogenic fluid, sometimes scar tissue is filling the bicipital groove, which is giving like as if there is a biceps tendon. You're not sure what is going on here, and is there a thin biceps tendon or not? Sometimes it is tricky So once you angle the probe and see if this whatever structure is in the bicipital groove is showing anisotropy or not, then it will help us. So if this structure, whatever is in the bicipital groove, is not showing anisotropy, i.e., it is not changing its bright to hypoechoic on angling the probe, then it is not a tendon, because it's the characteristic of the tendon to show anisotropy. So you can say that there is no biceps tendon, it is ruptured or dislocated. So you can use the anisotropy to your advantage. Other tip I want to give for people who are doing a shoulder ultrasound. Sometimes it is we always examine the tendons, the rotator cuff tendons in two planes, as you know, and this is the transverse plane where you get a nice rounded appearance of the long head of biceps, and we also look at it in the longitudinal section, and sometimes it is difficult to get a nice picture of this. So what I tend to do is to press on the toe end of the probe, which is towards the distal end of the probe. If you slightly angle it and press on the distal end, you are likely to get a better picture of the longitudinal section of the long head of biceps. Another important tip or pitfall in examining the long head of biceps tendon. Sometimes we don't examine the long head of biceps all the way up to the pectoralis major attachment, which is like more distally. That's exactly where the if the tendon was ruptured, that's exactly where the distal end of the retracted tendon would be lying. So it's always important to scan more distally all the way up to the pectoralis insertion, so that we don't miss the retracted tendon. Because sometimes the proximal tendon can be filled with blood or echogenic material. Sorry, excuse me 1 minute. Close the door. Sorry. It can be filled with echogenic material and give a false impression of that tendon is still there. However, as you can see here, the tendon is ruptured, and you can see the distal end at the level of the pectoralis. So other tip or pitfall that happens with an inexperienced hand is the not examining the free edge of the long supraspinatus. So if you see, this is the supraspinatus, and this is the free edge of the supraspinatus, and this is the long head of biceps. So getting this kind of picture where there is no gap between these two, long head of biceps and the free edge of the supraspinatus, is very important when examining the looking for tears under ultrasound. One of the blind spots can be the free edge, and we examine the patient with his hand on his back pocket and closely examine this area as well. Sometimes these free edge tears, where you can see here, this is the long head of biceps, and there is a tear here, full thickness tear. So these can be missed. So always examine the free edge of the supraspinatus. It is important to get these pictures so that you excluded the subtle tear in that area. So sometimes when there is a lot of tendinopathy, the tendon looks very delaminated, hypoechoic. It is difficult to, or it is easy to miss small tears. So there are some secondary signs which will help us look at the tendon more closely to avoid missing these type of tears. So the tendinopathy can underestimate the underlying tears. So there are a couple of secondary signs of a cuff tear, one of which is sagging of the bursa. You can see this is nice and concave bursal surface, and then there is a little sag in the bursa. So there is some volume loss in the tendon. So this is a subtle sign saying that there is volume loss in the bulk of the tendon. Some of the fibers are missing. So when you see this bursal sagging sign, then you should more closely look at looking for a partial thickness tear. So this is or sometimes a full thickness tear. So this is a sagging bursa sign, and there is another sign called a cartilage interface sign, where the cartilage of the humeral head is seen as a sharp, bright line when there is underlying tear, especially a tear which can be filled with fluid. For example, another example showing a cartilage interface sign, you can see there's a big tear which is filled with echogenic fluid, and it's sometimes difficult for an inexperienced eye to spot the tear itself, because the volume is not lost because it's filled with fluid. So it is very important to know that the sign exists, and this can say that there is a tear, underlying tear. So these are the two signs. This is all a tear filled with fluid, echogenic fluid. And so you can see the difference. And sometimes putting some pressure on it, you can see that fluid is moving. That is also another tip to see if there's to determine the tear. So this is another. Some of the my juniors, they're not aware of the actual anatomy, and the infraspinatus has got a big footprint, and there is an overlap between the supraspinatus and infraspinatus. There's a conjoined tendon, where you can see the diagrammatically represented here. So when you are describing the tear, the location of the tear, you have to keep in mind that there is a conjoined tendon and there is a lot of overlap between the supraspinatus and infraspinatus. So this is one of the anatomical points you should remember when giving in a report this location of the tear. So a lot of times it can be at the junction of these two, supraspinatus and infraspinatus, and it can be the conjoined tendon itself. So these are done with the ultrasound. So we'll go through some MR mimics and pitfalls. So I've gone through, tried to go through like bony, labral, tendon related, bursal related, and some joint related pathologies or mimics. So we all have seen the Hill-Sachs lesion on the X-ray and CT scan. It's very easy to identify the Hill-Sachs lesion in anterior shoulder dislocation. This indentation. However, sometimes on MRI, some people misinterpret. There is a normal smooth indentation of the humeral head of the posterolateral aspect of the humeral head. So how do you differentiate a normal indentation of the humeral head through a Hill-Sachs lesion is also important. So this smooth indentation is normal, and the Hill-Sachs lesion actually is at the level of the coracoid process. So you always look for the coracoid process, see if this is a Hill-Sachs lesion or is it just a normal indentation. They look very similar, mind you. So we need to, this is more distal and this is more superior, is at the level of the coracoid. So always correlate with your coracoid where the Hill-Sachs lesion is. Just for scoring more points when you are describing a Hill-Sachs lesion, you can actually measure the circumference and say how much of the humeral head bone loss is there. This helps the surgeon to determine what type of management. So if it is a small lesion, i.e. less than 25% of the circumference of the humeral head is involved, is conservative treatment. If it is a big, if it is 25 to 40% of the humeral head is involved, or bone loss, much larger bone loss, so the arthroscopic procedure such as this is done. And if larger lesions, then the patient, more than 40% patient will need bone grafting. So if you are able to quantify the bone loss of a Hill-Sachs lesion, it is a good idea. It gives a better impression, and your surgeon will be pleased. Okay, coming to another pitfall, the hemopoietic marrow in the proximal humerus. So usually in the medial aspect, there is this hemopoietic marrow, which looks dark on T1 sequences and bright on, this is a PD FATSAT image. As the patient's age, the hemopoietic marrow gradually recedes. And there is after 25, you wouldn't see a lot of hemopoietic marrow in the humerus, but there are certain variations, or some people, especially women, because of their physiology of menstruation. Some smokers, people with anemias, they can have persistent hemopoietic marrow. Sometimes hemopoietic marrow is misinterpreted as bone marrow infiltration. So how do you differentiate bone marrow infiltration from a normal hemopoietic marrow? You compare on the T1, you compare it with the muscle, and if it is lower than the muscle signal, then you would worry about a hemopoietic marrow. Other things would be cortical destructions and all that, but when there is no other sinister signs and you just see a hemopoietic marrow, you look at your T1 images and compare it with the muscle signal, and then you, if it is lower than the muscle, then you should worry about infiltrative process. Okay, another pitfall is when we are reporting the shoulder MRI, we always look for any undersurface bony spurs of the AC joint or the acromion. Here it looks like a bony spur here, which can cause impingement. However, this dark signal here is actually the deltoid attachment. And it's always good to look at the T1 images to see if this is like actual bone or is it just a low signal. So if it is bone, it would show some bony architecture and bone marrow. So this is actually not a spur on this PD FATSAT image, and T1 does not show any bone or bone marrow. And then if you have plain film also, you can compare. There is no actual spur or bony spur here. So it is a deltoid attachment, prominent deltoid attachment, mimicking a bony spur. So this is how bony spur would look like on a T1 sequence, which is deltoid attachment is here, and that is the bony spur, which can cause impingement, and you can correlate with your X-ray if there is a bony spur or not. So as acromial, it is one of the common anatomical variations. Usually appears at the age of 15 and fused around 25 years. So it can be a normal variant. It should not be misinterpreted as a fracture, especially in the younger age groups. and so it's about 5% of the people have acromegaly. And when you, especially on the MRI, when you're looking at the MRI, you should always look at the top few slices on the axial, which is the best series to identify the acromegaly. So always make sure that you look at all the images on the axial and exclude presence of osteoacromegaly. Osteoacromegaly, although is a normal variant, can be symptomatic, it can be unstable, cause impingement, and if it is unstable, it can cause a lot of bone marrow edema, like in this patient. How do you recognize acromegaly from the joint of acromegaly from the AC joint itself? There's a couple of differences. So the AC joint is usually at the level of the musculotendinous junction, which is here, and so is more medial, but the acromegaly is more lateral to the musculotendinous junction, and acromegaly joint is more posterior as well. So that is how you differentiate between the AC joint on the acromegaly on the coronal images. If you're not careful, we can easily overlook it. Okay, so you when patient is elderly and there is a lot of rotator cuff pathology, you see a lot of endosopathic changes, cystic changes in the humeral head at the attachment sites. But if you see in isolation, if you see cystic changes in the humeral head, in the lesser tuberosity, here you can see both in the greater tuberosity and lesser tuberosity. But if you see in isolation in the lesser tuberosity, then one should worry about subcoracoid impingement. This is the coracoid process, and the coracoid space is reduced here, subcoracoid space, and this can cause. It's controversial how much the space should be. They say anything less than 6 millimeters can be pathological, and this can lead to subscapularis tendinopathy and impingement, subcoracoid impingement. So when you see in isolation cystic changes within the lesser tuberosity, think about subcoracoid impingement and just see if there is any reduced space. And again, if you see cystic changes in the humeral head, superiorly, so this is in isolation, can be especially in young people who do a lot of push-ups and go to gym. This can be a sign of posterior-superior impingement when you see it in isolation. And here you can see there's a bit of labral rounding up of the labrum and a little bit of thickening of the infraspinatus. And this cystic change was secondary to this 40-year-old who does a lot of push-ups and a lot of gym activity. Now there's a spectrum of these labral tear mimics. So on the axial MRI, the first one or the very common one that we come across is a Buford complex, where it mimics like as if there is a detached torn labrum, triangular cord-like structure here. This is actually a normal variant. So if you see on this diagrammatic picture, there is absence of the anterior superior labrum from 1 o'clock to 3 o'clock position, and the middle glenohumeral ligament is cord-like. So this is cord-like middle glenohumeral ligament and absence of the anterior labrum, which can be misinterpreted as a detached labrum. This is a normal variant. Another normal variant. So all these normal variants happen between between 1 and 3 o'clock position or 12 and 3 o'clock position. So if you ever you see a tear or a abnormality, labral abnormality in these 12 to 1 o'clock, 12 to 3 o'clock position, always think, is this a normal variant or not? So again, this is middle glenohumeral ligament, and this is the anterior labrum, and this is the middle glenohumeral ligament. When they are close proximity, I'll show you another example, which is the next picture. This can look like a tear. This is not a tear, just a on one slice. If you just interpret on one or two slices, then this can look like a tear. However, this is just middle glenohumeral ligament giving a tear-like appearance. So on the coronal plane, you can, there are like 3 types of normal variants which can mimic a tear. So one is a cartilage undercutting, where the hyaline cartilage of the glenoid undercuts the labrum and can give a tear-like appearance. Pseudo slap lesion, which is the P here. I'll show you the pictures. And then the sublabral recess, which is the R, represented here, and then actual slap tear itself. So as I said, most of these normal variants happen between the 11 o'clock and 3 o'clock position, and most of the pathology occur below 3 o'clock position. So remember this, very important. So this is on the coronal MRI, a pseudo slap lesion. So basically, when there is close proximity between the, this is the biceps, interarticular biceps, and this is the labrum. So when there is a gap between the labrum and the biceps tendon, it can mimic a slap tear. It's called pseudo slap lesion. And this is another anatomical variation where there is the hyaline cartilage undercuts the glenoid labrum, and this can give rise to a, if you are not a careful observer, you might misinterpret this as a tear. However, if you see this is gray in color. This is the cartilage, which is gray in color, unlike the fluid. So if it is a tear, it should be filled with fluid. The fluid is more brighter. So that is how you differentiate the undercutting of the hyaline cartilage, which is a normal variation. Again, the sublabral recess is the third example, where there is a recess between the hyaline cartilage and the labrum, where the contrast can go there or fluid can go there and can look bright. However, if you see the direction of the propagation of this sublabral recess, it is going more medially. And this is a normal tear, normal slap, it is a slap tear, pathological, which is extending laterally. It's going like this. So there are 3 differences which you can differentiate the sublabral recess from the slap tear itself, which is, one is going medially, the sublabral recess is going medially, and the slap tear going laterally. This slap tear will have bit of ragged margins compared to the sublabral recess, which has very smooth margins. And usually this is less than 3 millimeters in size, and slap lesion can be larger than that. So the actual sublabral recess is located at the biceps anchor, but this can be traced back posteriorly as well. Located at the biceps anchor, the slap tear can be traced posteriorly. So these are the differences, how you differentiate the sublabral recess. Again, I said, show another example. There is sublabral foramina, again around 2 o'clock position, where there is a, this is the posterior labrum, This is posterior labrum, anterior labrum, and there is a foramina here. And this is the middle glenohumeral ligament. So if I remove the, so this is a sublabral foramen, which can also mimic detached labral tear. Again, the clue is that it is between 11 o'clock and 3 o'clock position. So it's a normal variation and it's not a tear. Again, I told you that the middle glenohumeral ligament also can give a tear-like appearance, like you can see here. So, okay, we are done with the labral tears mimics. Sometimes there are prominent blood vessels, especially when they are in the supraglenoid notch area. Like here, these two examples, these are prominent blood vessels, and this is a paralabral cyst. So how do you differentiate blood vessels from paralabral cysts? So basically, you follow the blood vessels up and down, and you can see that they lead into other vessels. Other thing is, you can, and in this patient, you can see that there is a labral tear, and you can see this paralabral cyst tracking into the labrum or towards the joint. The blood vessels, you won't see them tracking into the joint, but paralabral cyst, you can follow them into the joint. It's very important to know the differences between the subscapularis bursa and subcoracoid bursa, especially on the MRI. So they both have important differentiating features. So if you see here, this is the subscapularis tendon on the sagittal sequences. So the subscapularis bursa is like a saddle shape and usually sits on the top of the subscapularis tendon like this. And this is the coracoid process. And below the coracoid process is a subcoracoid bursa. So again, you can see the same thing on this picture also. This is the subscapularis bursa and subcoracoid bursa. So the subscapularis bursa is an intra-articular bursa. So if there is fluid in the joint, it goes into the bursa, which is so fluid. If you see fluid in the subscapularis bursa, it can be normal. However, if you see fluid distension of the subcoracoid bursa, then it is abnormal, or it's usually because there is a tear. So I just made this picture again, and this diagram shows clearly the shape of the subscapularis bursa, showing the anatomy very well. And this is the coracoid process, and there is a sausage-shaped subcoracoid bursa. So the location is important. We already discussed that it is saddle-shaped and sitting on the top of the subscapularis. This is just below the coracoid, and it can extend more distally. This one stops more proximally, the subscapularis. And so caudal extent, communication with the joint, I already told you that the subscapularis communicates with the joint and subcoracoid does not. Subcoracoid communicates with the subacromion subdeltoid bursa. And presence of fluid usually physiological in subscapularis bursa, and if you see it in the subcoracoid bursa is pathological, usually secondary to a tear, full thickness tear. Coming to the sticking with the abnormalities of the tendons, So on this image, you can see that subscapularis looks very thick and abnormal. However, you can see that patient hand is internally rotated, and this can be corrected, or if you do a externally rotated proper neutral position or external rotation in MRI, you can see that this tendon looks nice and thin and normal. So positioning abnormalities should always keep in mind. Sometimes they can look abnormal. Again, I think most of you know about the magic angle and how to deal with it. When you're looking at a tendon which at an angle of when the tendon fibers are at around 55 degrees to the magnetic field, it can give a pseudo bright appearance within the tendon, and it can be mimicked. It can be interpreted as this high signal within the tendons can be interpreted as a tendinopathy, especially on PD sequences, which have short T. This magic angle phenomenon is very common, especially in the biceps tendon and in the supraspinatus tendon. How do you deal with it? You look at the corresponding T2 sagittal image and any other T2 images available, and if the high signal in the tendon corresponds to the high signal in the T2 also, then it is tendinopathy. Otherwise, it can be safely said that this is magic angle related, not real abnormality. So always look at T2 images instead of PD. You rely on T2 images for diagnosing of tendinopathy. So sometimes it is difficult. It may be difficult to differentiate between tendinopathy and a small intersubstance tear. How do you differentiate them? Again, you can see there's a lot of high signal within the tendon. Tendon looks thickened. However, the intrasubstance high signal is not as bright as the fluid within the joint. So if there is a tear, it should look as bright as the fluid in the joint. So you always compare that. I can say that this is not a tear, this is just a tendinopathy change. There's a little bit of internal delamination. There is no fluid there. So it's just tendinopathy. And you can see that there is a tear, and it is the brightness is similar to the brightness of the intra-articular fluid. There's a foot plate tear with delamination. Again, when looking at the tendons, there are some blood vessels going along the tendons, which can be misinterpreted as delamination or intrasubstance tears. However, again, you need to follow these high signal areas. Usually these are branching. When you see the real images, you can see them, they're branching and joining other vessels. That is how you differentiate them. Do not make a diagnosis just seeing on one image. Always look at, you can see that there's a blood vessel which is branching and joining other vessels in this area. So this is blood vessels can mimic intrasubstance delamination. Sticking to the tendons, Aber position is one of the special positions we do the MRI. Is abduction external rotation. So patient lies in with his shoulder abducted and hand underneath the head in external rotation. This is a very not so comfortable position, and patients, if they have acute injury, recent acute injury, it may not be the ideal imaging sequence to do, but later on when patients symptoms get better, when you're imaging for subtle abnormalities. It is always better to include the ABO position. So this ABO position, what it does is it stretches the anterior-inferior glenoid labrum, and it is more sensitive in picking up Perthes lesions and partial surface tears of the intra-articular partial surface tears of the supraspinatus. So here you can see that a normal position, it is not clear if there is a tear here or not. There is a displaced labral tear here. However, in the ABER position, you can see that there is a Perthes lesion with periosteal elevation here. Again, the ABER position here, we do not see any supraspinatus tear. However, in the ABER position, sorry, these are our orthograms we're talking about. These ABER is specifically for doing when you're doing an orthographic study. Here you can see that there is a partial thickness articular surface tear of the supraspinatus. Here you can see that, and there is a bit of delamination as well. So the ABER position can be used routinely in orthographic imaging to see if there's subtle abnormalities. Another anatomical variation which can be misinterpreted as biceps tendon tear or delamination is accessory biceps tendon. Some people have accessory biceps tendon, which gives this kind of appearance, split kind of appearance. Basically, it is the tendon itself is dark and nice, so there is no thickening or intersubstance signal change within the tendon. That you can see two tendons, two split tendons. So this is accessory biceps tendon. But when you see actual delamination, you'll see that there's thickening of the tendon and there is intersubstance signal changes more. And there is some fluid in the tendon sheath as well. Sometimes when there is enough fluid in the tendon sheath, you see the vincula or a mesotendon of the biceps tendon sheath. So basically, the biceps tendon gets blood supply from this little mesotendon, which is a normal variation. It's not an adhesion or a pathological. This is a normal anatomy. So this should not be misinterpreted as adhesion. So this is just an example showing calcific tendinopathy within the musculotendinous junction of the supraspinatus tendon. And this another patient showing a calcific tendinopathy of the infraspinatus, which is invading the bone, and there is a lot of bone marrow edema. So this picture just to show that what can happen to the calcific tendinopathy. There is calcific tendinopathy within the tendon. It can go into the bursa and cause calcific bursitis, which is very painful condition. It can mimic septic arthritis as well. It's quite inflamed bursa, and there's a lot of fluid in the bursa. So the calcium can rupture into the bursa and cause calcific bursitis. Or it can migrate more into the muscle or into the musculotendinous junction, and it can cause, as in this patient, a lot of edema and a lot of symptoms and even impingement as well. Then it can extend into the bone and cause bone destruction, bone indentation, a lot of bone marrow edema. Again, this is very painful. So this is kind of, and then obviously it can rupture into the joint itself and cause a lot of joint inflammation as well. So the calcification within the prototype of tendons can lead to any of these complications or can progress to any of these conditions. So to remember that. Frozen shoulder, it has been when I was in medical school, or when I was training, frozen shoulder was said to be a clinical diagnosis when there is global restriction of movements and no imaging was indicated in those days when I was doing my orthopedic training in UK. However, there are very nice and very good signs of frozen shoulder, reliable signs of frozen shoulder on MRI. Ultrasound is not that good in ultrasound, or any other imaging modality is not that good, but MRI has specifically three findings. One is the fibrovascular soft tissue thickening in the rotator interval. As you can see here, the rotator interval, there is a lot of edema, and fibrovascular soft tissue thickening is there. Sometimes you can see this on the ultrasound. And there is a subcoracoid fat pad, you can see here. Usually there is a fat pad below the coracoid process. When there is a lot of inflammation in the rotator interval, it can spill into the subcoracoid fat pad and it can get effaced like here. So the bright fat pad is, especially if you do, you'll see this only if you routinely do T1 coronal images on your sequences. Sorry, not coronal, the sagittal images. So not everybody does the T1 coronal images. So this is one of the indirect signs of frozen shoulder or adhesive capsulitis. And more commonly, you can see the marked edema and thickening of the inferior glenohumeral ligament or the joint capsule, inferior joint capsule of the glenohumeral joint. This is when you see this one, the axillary recess on the coronal images, it is very pathognomonic of frozen shoulder. And when you do an orthography on these patients, this is a non-orthographic image, but if we do orthography, there's hardly any distension of the axillary recess of the joint, and it's very hard to inject the contrast. So you will feel a lot of resistance, and you'll see that there is not much distension of the axillary recess of the joint itself. We usually inject about 10 to 15 mils, but maybe you can't inject more than 5 to 6 mils in such patients. Now coming to some rare variants, there's something called Asaki tubercle, where there is a subtle bump in the cortex of the glenoid. There is a little bump. So the cortex goes like this. There's a little bump there, and there is lack of cartilage over that bump. So this is a normal variation. It's just a small bony protuberance with thin cortex or no cartilage on it. So this is called, this is a normal variant, and it was described by a French anatomist. Again, similar to the Asaki's tubercle, there is an indentation or a bare area of the glenoid where there is a little concave appearance with no cartilage. This is called bare area. This can be on the humeral head as well. There's a physiological bare area of the humeral head where can be seen on the posterolateral aspect of the humeral head. You can see the cartilage all the way up to here, but there is no cartilage. This is it's just a normal variation. So we need to keep that in mind when calling these, especially these are orthographic studies, pathology. So this is a normal variation. When you're doing orthogram, again, you can inadvertently inject air bubbles, where you can see the air bubbles, which can mimic loose bodies. So firstly, we should take all precautions not to inject air bubbles in the tubing when you're injecting the contrast. However, sometimes things do go wrong, and you can end up injecting small air bubbles. So you should know how to differentiate the air bubbles from loose bodies. So usually air bubbles are floating, and so they are not in the dependent part of the joint. So that is how we differentiate them. But sometimes if there is too much, it can be very tricky, and it can obscure some of the important structures. So sometimes when you look at the lower slices near the axillary pouch, you can have a very jagged appearance of the inferior glenohumeral ligament with a lot of folds. So this is also a normal variation. So of the inferior glenohumeral ligament, and it can simulate as if there is synovitis or some kind of pathology. But however, this is also orthographic study showing a jagged appearance of the. You don't find this all the time, but sometimes this kind of appearance is seen, and this is a normal variation, not pathology. Okay, so that is the end of my talk. So we've gone through various pitfalls and some pearls, and we've gone through how to interpret them and how to overcome these pitfalls. So we've gone through various pathologies also. That is my end of my talk. This is a small video of my recent sorry. This is the view of Mount Everest from Kalapathar, and so this one is the Mount Everest, and there are other mountain ranges. And this is me and my close friend. Sorry. Thank you. That is the end of my talk. Thank you so much for bearing with me, and we can.
Thank you, Vijay, for an excellent presentation. Really, these are the common mistakes and it's good for the youngsters to know the pitfalls of the shoulder. Over to Dr. Vijay Bhaskar.
Good evening, Dr. Vijay. That was a fantastic presentation, sir. What are the common things what we come across while reporting? You have mentioned really, I mean, very practical points which are very useful for everyone.
Thank you, sir. Thank you.
And your Himalayan, the photo of Himalayas also is video also was superb, sir. Keep rocking like this.
Thank you, sir.
Thank you so much, sir. Any questions from anyone who wants to ask? Sir, can I ask one question?
Just one comment. You know, it's a beautiful presentation. It's very useful for all the residents and also for the practicing radiologists. Very useful practical points, and thank you very much.
Thank you, sir.
Can I ask one question, sir, Vijay, sir?
Sure.
Sir, very often we see that this subscapularis tendon, it is increased thickness and some increased T2 signal intensity. When should we call it as tendinosis? When should we call normal? Are there any variants and are there any pitfalls there, sir?
You're talking about MRI, right?
MRI, yes, sir.
Yeah, I mean, I do a lot of ultrasound,
Okay.
and so basically the commonest tendon that goes impingement is supraspinatus.
Yes, sir.
So usually I compare it with the supraspinatus. Even mainly subscapularis and supraspinatus are the tendons that undergo impingement, and I usually compare with the supraspinatus.
Okay.
And then any decrease in the normal hypoechoic appearance of the tendon, we can safely call it as tendinopathy, because once another tendon, if supraspinatus is completely normal, then I would have some reservations of calling just subscapularis, unless there is isolated subcoracoid impingement, or subcoracoid space is really narrowed.
Okay.
Other secondary findings would be, if there's any cystic changes around the lesser tuberosity, especially around the lesser tuberosity. It also means it's an indirect sign that there is impingement going on, or some kind of either it's a sports person doing some kind of sporting activity. So those secondary signs will help us if it is completely isolated.
Thank you, sir. Thank you, sir.
Thank you.
Any other participants want to ask question, please?
Yeah, excellent presentation, Dr. Vijay. I'm Dr. Rajgopal. You were showing one case of slide number 43, I think. Was it a Rembrandt tear? And I just want to know when exactly you call it as a Rembrandt tear.
43.
Yeah.
Can see it?
No, I think you're not shared.
Okay. Yeah, I mean, this is you can call it a foot plate tear or a Rembrandt tear, but it has got an extension into the tendon. So there is something called there's some fancy names, but usually I tend to describe it. There is a concealed CID and all that, concealed tear, and there are a couple of nomenclature are there, but I tend to describe it and say there is a foot plate tear and it extends into the tendon itself. You can call it Rembrandt tear, yeah.
Okay. One more question. While doing ultrasounds and all, no, in supraspinatus tears and all, we classified into anterior, middle, and posterior fibers, especially when you're classifying it. When you're calling it as an infraspinatus tear, no, a partial tear, how exactly you classify? You classify it as a superior fibers or inferior fibers, or how exactly you do it?
See, conjoint tendon, it's kind of, you can't really delineate on ultrasound or MRI, but we should know that there is a concept of conjoint tendon, and these fibers intermingle in the middle of the
would you describe it as a superior fibers or inferior fibers or anterior, posterior? How exactly you use in infraspinatus?
I'll say superior fibers of the infraspinatus. If it is close to the supraspinatus, I'll say posterior fibers of the supraspinatus and anterior fibers of the infraspinatus. So if suppose the conjoint tendon is involved, I'll say posterior fibers. So I think in terms of I'm standing before the patient doing ultrasound scan. So to me, the conjoint tendon involvement is like posterior fibers of supraspinatus and anterior fibers of infraspinatus.
Do you want to call it as anterior fibers or superior fibers of infraspinatus?
That depends on your communication with your orthopedic colleagues. So, so if you have understanding between you and so they will understand your report. So if you've been working with certain group of orthopedicians, then it becomes easy. So the terminology, you can ask them what they would want it to call, and you can give their nomenclature, because there's so many nomenclatures, classifications. So always better to describe and always have a rapport with the orthopedician. So for me, I usually describe as posterior fibers of supraspinatus and anterior fibers of infraspinatus.
Okay, thank you so much.
Thank you.
Excellent presentation.
Thank you, sir.
Any other questions, sir? So if none, thank you very much, Dr. Vijay. It was a great presentation, sir. We would like to upload it into the Crest YouTube channel, sir, if you permit us.
Sure, sure.
Thank you so much, sir.
Okay, sir. Thank you.
We'll close the session.
Thank you, sir. Bye.
Thank you. Thank you.